So, good evening, all the aspirants present here. Today, we have the topic is acute coronary care, and the speaker that we have here is Dr. Sangshaptak Saha, who is the Associate Consultant Critical Care Medicine at Apollo Hospital, Kolkata.
Hello everybody, I'm Sangshaptak. So today's topic for discussion is acute coronary care. Firstly, we shall have brief theoretical aspects of the acute coronary syndrome, mostly both STEMI and non-STEMI, and in the end we have a few ECGs just for the more practical aspects. It will be something like 40-45 minute session at max. Okay, so let's start. So when I was doing my DM at AIIMS Delhi, acute coronary care has always been, one of the common topics not only asked in the grand rounds but also in the entrance exams, as well as it was asked in my DM exit exams as well. Because not only in the cardiothoracic ICU, but this acute coronary syndrome can occur in any patient in an ICU, the sepsis patients, the AKI patients, then the simple patients with pneumonia, with ARDS, just because of the oxygen uh, at delivery and need mismatch, it can occur. So let's start. So in 2018, the fourth universal definition was given, and we have come a long way from 1950 to 2018. Where there is definition, what they state is mostly it stated that there is a clinical part and there is a pathological aspect. So the clinical aspect stated that so there is a clinical aspect and a pathological aspect. The clinical aspect stated that obviously stated that there should be a presence of acute myocardial injury, for which we shall understand by abnormal cardiac biomarkers. And the pathological definition is that there will be myocardial cell death as a result of prolonged ischemia. And this rise in abnormal cardiac biomarkers, that is defined as an elevated cardiac troponin value above 99% of upper range of normal limits. So the myocardial injury related to acute myocardial ischemia can occur because of the atherosclerotic plug disruption. It can occur as a stelling because of myocardial injury because of the oxygen supply demand imbalance. It can occur because of reduced myocardial perfusion or increased myocardial oxygen demand. So if there is increased myocardial oxygen demand, that can occur because of the tachyarrhythmias or simple tachycardias or severe hypertension. So a patient who has got a heart rate of more than 140 or 150 beats per minute, which is common in any case of sepsis or trauma patients. So in all of them, there is a more chance of this oxygen supply demand imbalance. Other than that, if there is reduced myocardial perfusion because of the opposite, that is bradyarrhythmias, because of persistent hypotension or shock, once again it can occur in a general ICU. This hypotension or shock, respiratory failures, severe anemia, yes, hemoglobin less than 5 grams per percent, which is mostly in a case of hemorrhagic shock or in trauma patients or a post-op patients, mostly in those intra-op or post-op patients. And these are the cases which we mostly see in a cardiac ICU. That is vasospasms, embolisms, coronary artery dissections. Apart from these three cases, all of them can occur in a general ICU also. And of course, this can occur in any patient with the risk factors like diabetes hypertension, obesity, then elderly patients, uric acid high, age, right? Then smokers, that all the risk factors that we know of. Smokers, then alcohol consumption beyond the normal limits, all of these things. So basic point is that etiology can be varied. It should be suspected in any patient who has got a shock, in whom we are seeing there is a rise in lactate, who is having a cold perfusion, cold peripheries, and of course echo is machine is available, the bedside focus machine, that is the echo machine, and all the people who are working in an ICU, right from the RMOs to the the consultants or the associate consultants or whoever is working, they should be at the bedside. They should be able to do a basic echo to rule out the RWMA, regional wall motion abnormality, and to look at the and to get at least a basic estimate of the ejection fraction. Okay. So moving on, other causes, we all know that there can be separate other causes. The cardiac conditions we won't discuss. The systemic conditions like sepsis, infections, CKD, subarachnoid hemorrhage, pulmonary embolisms, then the chemotherapeutic agents, especially the doxorubicin, daunorubicin, in general critically ill patients, and these amyloidosis, sarcoidosis, I think are not that common. Sarcoidosis is a bit common, especially if you're working in a pulmonary ICU like I am. But amyloidosis, yes, it's a bit rare. So, lot of systemic conditions can cause this oxygen supply demand mismatch. And among the cardiac conditions, you all know it can be heart failure, myocarditis, then coronary revascularization, that is post-procedure, as well as defibrillator shocks. So classification of MI, it is dependent upon how the MI is occurring. Type 1 is mostly because of the myocardial infarction where there is a atherosclerotic plaque rupture or damage. In type 2, there is oxygen demand and supply mismatch. In type 3, it is associated with sudden cardiac death. Type 4 is associated with the type 4 and type 5 are associated with the procedures. Type 4 is associated with PCI and type 5 is associated with CAPG. So type 1 AMI, how to diagnose it? So diagnosis is pretty straightforward. There will be the symptoms, that is the chest pain, new onset ischemic ECG changes. Over hours, after 4 hours, if you repeat, there will be the pathological Q waves which can be absent if you are doing an ECG early enough, or if the patient has presented early enough. And the echo evidence of new loss of viable myocardium, that is a new regional wall motion abnormality, which was telling, it's the bedside echocardiography will diagnose it. And finally, this is the cardiologist domain, identification of coronary thrombus by angiography, right? So one is, so these are the important things. So this is the clinical history, right? Signs, symptoms of a crushing chest pain, a very severe chest pain, which is a central in location, which is not identifiable by single finger. So pinpoint location not be possible. If it is possible, then the chance of being a cardiac chest pain decreases. Then the pain relating to the jaws, to the inner surface of the arms, towards the interscapular space. Although the specificity is very less, but if the patient in an appropriate clinical condition is demonstrating these signs or telling these symptoms specifically, be alert, it can be a AMI feature. Then of course you are doing the ECG. There are two things. These will be the fresh ECG will also show these ischemic changes, that is the ST depression, ST elevation, QOF changes, and QOF changes will be in the second ECG. But if the patient has delayed, if the patient has appeared at 4 hours, 5 hours, then the QOS can be in the first ECG also. This is the echo, which can be done at the bedside. And finally, this is the cath lab finding. So this was about type 1 AMI. Type 2 AMI is almost same. Symptoms are same. Ischemic history changes are same. Pathological QFs is also same. Echo findings are the same. The only thing is that because here it is an oxygen supply demand mismatch, so this feature, the coronary thrombus by angiography will not be present. Okay, so type 2 AMI is there. By definition, the acute plug disruption will not be a feature of type 2 AMI, and this is the most common AMI in a general ICU. And then we move to the type 3 AMI and type 4 AMI. These we shall discuss later on also, so I'm not discussing it here. Type 3 AMI, patients who did not give us a chance to investigate and have died. So basically an autopsy finding, right? Type 4, which is the related to the PCI. So if the PCI, the cardiac troponin changes will be more than 99% of the upper limit of the normal, or more than 20% of the baseline value. So type 4 AMI, there will be the fresh changes, fresh QF changes, imaging evidence, echocardiography, and angiographic findings. The only thing absent are the clinical features because it is a post-procedure. So the clinical feature, that is the typical chest pain, will not be there. So the clinical feature classically absent. Why? Because it is post-procedure and it should occur within 48 hours of the procedure. And the cutoff is 5 times. So the cardiac troponin should be more than 5 times and it should occur within 48 hours of the procedure. I hope my screen is visible, right? Type 4B. Type 4B. So 4A is these things and 4B, the cardiologist has already placed a stent or a scaffold and a thrombosis has occurred there. That is a restenosis has occurred. And type 5 is almost same thing. It is just post CABG and there it is 5 times, here it is more than 10 times and it is same less than 48 hours and the clinical criteria are the same. So these are the 5 types of AMI very frequently asked in EDIC part 1. They will simply, the EDIC part 1 is not that clinical. They will simply ask you that this has happened, what is the type of AMI the patient has suffered from. By type, they mean this type 1 or type 4 or type 5. So if you just know the basic definition, you'll be able to answer. They will not ask you in details. It's an MCQ based exam. Epidemiology of AMI, I think I have already discussed about the risk factors: smoking, blood lipid levels, hypertension, diabetes, morbid obesity, less physical activity, excess alcohol consumption, and the diet. So these we have already discussed. This is the Indian classification in EDIC. You will not need this obviously, as I am not discussing. Clinical features of acute coronary syndrome. I have already discussed the typical chest pain. I have already discussed. So other than the chest pain, what will be the findings? So this is obviously the number one finding, right? The other findings are diaphoresis. In the EDIC exam also, they give a lot of importance to diaphoresis. Why? Because studies have shown that this is associated with worse prognosis. And then unfortunately the patients can also present with sudden cardiac death, right? So sudden cardiac death, that is very unfortunate, but that occurs. Sudden collapse or death can also be the presenting feature. But do remember this diaphoresis thing. They have asked about this diaphoresis in the exam, that the patient has got a diaphoresis and the young patient with diaphoresis, something like this. What is the most likely cause? Obviously, they have not mentioned about the ischemic chest pain. So next we come to features favoring non-cardiac chest pain. So how to rule out a cardiac? We have already discussed the features of cardiac chest pain. So the primary or sole location in mid or lower abdominal region. And as I told, any discomfort which is localized with one finger. So central location, but one finger. It is the patient is able to pinpoint the location. Very unlikely to be a cardiac chest pain, right? Because in ACE, what happens that acute coronary event, what happens is that a part of the myocardium is lost. So it cannot be a single point. It is usually over a more area that it is lost. If it is a constant pain, it is obviously not ACS. Fleeting pain, obviously not ACS. And the pain radiating to the lower extremities will not be ACS. Yes, penetrating to the jaws towards the towards the inner part of the radial part of the this what to call it the upper extremity. These specificities are very much less, but definitely a pain towards the lower extremity will not be the pain of this thing. And do rule out the pleuritic pain in whoever is taking the class on the pneumonia. This pleuritic chest pain is very commonly asked in EDIC 1. Once again, they will just tell you that the patient has this type of pain and they will ask you what is the most likely cause, and the answer will be pleuritic chest pain, a very favorite of the European people. I have given the MRCP also. So in MRCP also they ask about the periodic chest pain, and in EDIC also they ask about this. Not only this, but the heart zoster pain, then musculoskeletal pain. There will be an injury. So read the stem very carefully. The stem is often very long, so try to write the last part of the stem first, what they are asking, and then go start reading the stem from the top and go on excluding the differentials. That will, and definitely do practice it every day at least 1 hour. I know everybody is busy, most of you are working as in a higher post, so time will be less, but do try to practice this for at least 1 hour every day, if possible 2 hours, because otherwise time is an issue in EDIC 1 because the stems are so long. Anyway, so what are the causes of acute chest pain? These are not required. These are the cardiac pains and what I have to rule out. The in EDIC 1, what they will ask is that is ischemia infarct, aortic dissection, pericarditis, pulmonary embolism, and gastrointestinal. So these are the ones that they usually ask. The others are, not usually asked in EDIC part 1. These are the mimickers, and that is why they ask those things. Pericarditis, pulmonary pericarditis, usually that the patient will, they will have a history of effusion, or they'll give an ECG where there will be the concave shaped ST changes in all the leads, or there will be that the NSAIDs usually relieve the pain. So one of these 3-4 points will be there. So look out for it. Pulmonary embolism obviously is a separate topic, it's a separate issue. They will give a typical history of pulmonary embolism, a flight history, surgical history, immobilization history, and from there you'll get the idea. So coming to the diagnosis of acute coronary syndrome, the most important question is this, that what is the maximum amount of time that is allowed before you can do an ECG. So there they have got this ambulance, this hospital service is very rapid. They will take the ambulance, go to your place, and bring you from there to here. Obviously, that is also present in India also, but or in any other country. But there it is very much recommended that if the patient is complaining of a chest pain and is suspecting ACS, that is the EMS people who will be in ambulance, they will have to do an ECG as soon as possible, and the maximum time allowed is 10 minutes. It once again is a question which has been asked previously in EDIC 1, a direct question. What is the maximum amount of time that can pass before you do an ECG? So the answer is 10 minutes. If you know, you know. If you do not know, you will have to, leave the question. There is no other way. And these we shall discuss later on also. That the posterior, if you want to assess the posterior chest wall, you have to put in the V7, V8, V9. If you suspect a posterior AMI. If you suspect a right ventricular infarct, you have to put in V3R and V4R also. But these are practically not done, right? So posterior AMI usually will also have a features of inferolateral AMI. So the changes will also be there in lead 2, lead 3, as well as in the 1 AVL. And in the RV infarct, yes, if you put in V3 or V4R, there will be the ST segment elevations, but the ST depression also present in V1, V2 also. So from there you can get an idea. We shall discuss it in the ECG parts. Okay. So ECG criteria, this is just theoretical. New ST elevation at the J point in 2 contiguous leads with a cut point of more than 1 millimeter. This is for all leads. The only exceptions are V2, V3. So V2, V3, they have got an age and sex specific. So men more than 40 years, it needs to be more than 2 mm. In men under 40 years, it has to be more than 2.5 mm. And in all women, regardless of age, it is more than 1.5 mm. So list is For all women, 1.5 mm. Then for men, the cutoff is 40 years. So more than 40 years, a smaller elevation is enough. So more than equal to 2 mm if the age is more than 40 years. Otherwise, you need a 2.5 mm if the age is less than 40 years. So less than 40 years, chance of AMI is less. So the cutoff is also more. So the changes needs to be more. So this is for ST elevation. Remember, the ST depression has got a different criteria along with the TOF changes. ST depression more than 0.5 mm and TE inversion more than 1 mm in two contiguous leads. So this is the definition of AMI where there is no LBBB and no bundle branch block. Yes.